opportunity of speaking today, Dorothy. I'm going to talk about 2 and 5 year results from craniocervical fusions for Chiari or low-lying cerebellar tonsils in conjunction with craniocervical instability in the population of patients with hereditary hypermobility connective tissue disorders. So my goals today are that you understand that lax ligaments result in abnormal deformation of the central nervous system, and that the reason for craniocervical fusion in the population with Chiari malformation and hypermobility spectrum disorders. Be aware of the pitfalls and controversies in the management of craniocervical instability, and of course understand the outcomes of this surgery. So here's a Chiari. It's moderately impressive, even with a syrinx. And we ask, is the headache the result of the Chiari malformation? And in large series where they've performed suboccipital decompressions for Chiaris, about 20 to 50% have a delayed failure rate. And so Chiari decompression is not always successful. A number of people have addressed why the Chiari failed to give the relief of headache. And some have suggested ongoing ventral compression of the brainstem, ventral brainstem deformity, the fulcrum effect due to a retroflexed odontoid and basilar invagination, the presence of atlantoaxial instability, and craniocervical instability. Doug Brockmeyer published in 2011 and Bolo in 2012 in a series of 101 patients who had undergone Chiari decompressions. And 20% of these had undergone occipitocervical fusion because of the presence primarily of a kyphotic clival axial angle or the presence of previously undiagnosed basilar invagination. And Kleekamp looked at 45 revision decompressions for Chiari, and he said that deterioration was often related to craniocervical instability. And so he stressed the particular importance of looking for signs of instability when proceeding to decompress a Chiari. He said if functional studies in flexion extension demonstrate hypermobility of the craniocervical junction, then decompression should be combined with the appropriate fusion. Now, Gohl published on 200 of his patients with basilar invagination and instability, and he reported that the instability causes microtrauma, and this results in a pathophysiological process that increases instability, and it's a reverberating process that gets worse and worse. And it's worsened by malnutrition, vitamin deficiencies, and deconditioning, things that commonly happen in connective tissue disorders. Now, Millerite published in 2007 that 13% of his Chiari patients had a hereditary hypermobility connective tissue disorder, like Ehlers-Danlos syndrome. It's very important to remember that many EDS patients have Chiari-like symptoms without having a Chiari. This is a small caveat. Now, it's not hard to understand why a connective tissue disorder would have problems with the craniocervical junction, given that ligaments are what stabilize the skull on the spine. If you have a ligament disorder, you're going to get some degree of craniocervical instability. So one pitfall is the failure to diagnose a patient with hypermobility. We're talking about osteogenesis imperfecta, they have brittle bones, blue sclerae, frequently seizures, hearing loss, and many of them have basilar invagination. And Marfan syndrome, they have the long fingers, the arachnoidactyly, and they have the dissection. They can get a dissection of the aorta. Very frequently there's a pectus excavatum, which is a hole in the front of the sternum, or the cartilage can be poking outward, and that's called a pectus carinatum. They often have lens dislocation of retinal detachment and scoliosis. It's thought that George Washington and maybe Lincoln had Marfan's. Loeys-Dietz syndrome is just like Marfan's with the pectus carinatum or excavatum, They also have a bifid uvula. Many have craniosynostosis, which is premature fusion of the plates of the skull. And they have sort of stubby little fingers, and that's called camptodactyly. And these patients can develop aortic dissections as well. In Stickler syndrome, it's characterized by the small jaw and the flattened facial bones, and most of them have glaucoma, cataracts, retinal detachment, and hearing problems, which is why I always check carefully for hearing issues. They have scoliosis. But Ehlers-Danlos syndromes are the most common, and 20 years ago they'd refined it to about 6 diagnoses. Now we're up to 13 different types of Ehlers-Danlos, and one of the worst is the vascular type, which has rupture of the mid-sized arteries and sometimes rupture of the hollow viscera, aortic aneurysms. But fortunately, this patient of mine had a dissection of that right kidney, and you can see that there's no renal artery there because it had dissected. Fortunately, most EDS patients are the hypermobile type, and they appear to be quite common. The official word is that it's 1 in 5,000, but there are a few groups in Great Britain where they've done epidemiological studies, and they suggest it's more than 1 in 100. So Francisca Malfay and Van de Pep showed this case of a C1-2 instability and basal invagination in a patient with EDS. But there are many other forms of genetic compression of the brainstem. This patient had a segmentation failure where the C1 did not separate from the skull, and that creates instability between C1 and C2. That's called a HOXD3 homeotic transformation, and this is my patient. But we also see degenerative connective tissue disorders where abnormal movement results in pannus and compression of the upper brainstem, lower brainstem and upper spinal cord. So when does ligamentous laxity at the craniocervical junction become pathological? At a consensus meeting in 2013, 16 universities and hospitals representatives determined that there were 3 other metrics that would be useful in this population: the clival axial angle, the Grab-Mapstone-Oakes measurement, and the Harris. I'll go through those. So here's the clival axial angle, the angle between the clivus, which is that wedge-shaped bone at the base of the skull, right here, and that's the basion, and here's the odontoid. And normally the angle between the clivus and the odontoid is more than 150 degrees. But when you get an acute or a kyphotic angle like that, that's pathological. And so a number of authors, starting with Scoville and then Van Gilder, suggested this kyphotic clivoaxial angle can cause neurological deficits by they didn't specify exactly why, but presumably the fulcrum effect on the brainstem. And we did a very extensive review of the clival axial angle and published it in Neurosurgical Review last year, and it's available. We paid a little extra to make it available online for anyone who wants to get it. We also showed with finite element analyses 8 years ago how deformative stresses associated with the abnormal clival axial angle can cause pathological changes in the brainstem. And by reducing that deformative stress, we saw significant clinical improvements in the patients. So that was a finite element analysis study. Now, this is what I'm talking about. Here's a normal brainstem, and you see a subtle bend there at the skull base. But if you have a significant kyphosis there, then that causes stretching of the brainstem, and that results in neurologic deficits. Many people have noted the importance of the kyphotic clival axial angle. Now, another measurement is the Grab-Mapstone-Oakes measurement, and if you draw a line from the basion to the posterior inferior C2 and then measure the perpendicular, that should be, usually, 5 to 7 millimeters. If it's 9 millimeters or more, that represents high risk for ventral brainstem compression. The Harris measurement is, I think, really important. And Harris looked at 400 normal subjects and found that the basion never moved more than about 10 millimeters away from the odontoid. And if the basion was 12 millimeters away, that represented craniocervical instability. And so here's a patient with a Harris measurement of 15 millimeters, and that is clearly abnormal. Now, there's another aspect of the Harris measurement. I said that the basion normally resides over the midpoint of the odontoid right here. And so between flexion and extension, that basion is pivoting on the odontoid process. That's normal. But here's an abnormal. Here on flexion, the basion moves forward to 12 millimeters, Harris measurement of 12, and on extension it moves back to 7 millimeters. So that's 5 millimeters of sliding or translation, and it should not, the basion should not slide more than 1 or 2 millimeters. Now, we treat basal invagination with reduction, and I'll just show you that in a minute. We treat brainstem compression due to Chiari malformation with decompression, maybe opening the dura or whatever. We'll find out what the best way is soon. We treat the craniocervical instability with stabilization and fusion. So to look at this, we wanted to see how our patients were doing. So with an IRB through the Greater Baltimore with Claire Francomano and a larger research group, we looked at 20 patients. Typically, most of them were females, women, one male, average 25 years of age. All of them had cerebellar ectopia, so varying degrees of Chiari. Some were just low-lying cerebellar tonsils. All had a hereditary connective tissue disorder of one type or another. And we obtained some of the data through a third-party emailing survey at 2 and 5 years. 20 out of 20 subjects responded. The respondents made qualitative judgments about some of these questions, and I also performed the neurologic exam, and a radiologist measured the indices of instability. So our indications for craniocervical fusion are, after non-operative treatment, require that the patient should have failed non-operative treatment. They should have family support perioperatively. Local physicians should be involved in the care. And they should understand that surgery is a last resort. The headache or neck pain should be 7 or greater. They should have a cervical medullary syndrome. And I think Dr. Greenberg talked about the cerebellomedullary syndrome earlier, and very, very similar findings. And they should have demonstrable neurologic deficits and congruent radiological findings. So basal invagination would be an important criteria. And of the other criteria, I wanted 2 or more. The kyphotic clival-axial angle, translation of more than 4 millimeters by the Harris measurement, ventral brainstem compression, presence of a Chiari, or foramen magnum stenosis, or obstruction of CSF through the foramen magnum. I want to emphasize that the indications for craniocervical fusion are very standard. What's not standard is EDS. I mean, EDS is sort of new on the playing field, and as soon as you say EDS, then people forget why we're doing standard surgical procedures. We do the standard surgical procedures for standard criteria. And I know in England, for instance, one of the neurosurgeons up there wasn't able to get the patient on the schedule as an EDS case, but as soon as he simply stated the diagnosis of the problem, which was atlantoaxial instability, there's no problem doing it. There were standard indications. The patient did great. So now, one of the pitfalls is that with hereditary hypermobility connective tissue disorders, you need a dynamic imaging system. And this might be a flexion extension CT scan or an MRI, upright MRI. So you can see on the left that that image is acceptable. Most radiologists would say, but that's, fairly normal. It's not really, but it looks tolerable. But on the right side, on flexion, now there's retroflexion of the odontoid. And that's clearly meets all the criteria for basal invagination. So you need some form of dynamic imaging. Now, these patients, these were the symptoms. They had headaches, 100%, fatigue, dizziness, muscle pain, arm weakness, joint pain, neck pain, balance, night awakenings, memory problems, walking, arm numbness, Raynaud-type phenomenon. We're going in descending order of frequency, vision problems, leg weakness, vertigo, hearing, speech, and so on. Nocturia, irritable bowel syndrome, tremors, fainting, numbness in the back, sleep apnea. And for the surgery, and most of them had, or all of them had neurological findings, including usually some hyperreflexia, weakness, sensory loss, often some cerebellar findings such as dysdiadochokinesia, or sort of clumsiness of one or more limbs. So in the surgery, they're positioned prone, face down, with the head in a head holder, and we use intraoperative fluoroscopic CT unit. We do brainstem and spinal somatosensory evoked potentials, sterile prep of the neck, and then we were doing rib grafts, so we'd prep out the ribs, gentle handling of the soft tissues, and intraoperatively we'd do the reduction. So reduction merely means reducing the deformity. So in these patients, on the left, you can see a model of a person in a Mayfield head holder. And first we apply traction, pulling the head straight. We release the head holder. We pull the neck and then translate it posteriorly upward and then extend it. And you can see on the upper right, there's a kyphotic clival-axial angle of 130 degrees, and lower right, that angle has been, that bend, that kyphosis has been reduced, and it's 160 degrees, but the angle is reduced. And we look at, we don't usually use a ruler to measure these, but we look at the clival-axial angle. We want to get that more than 145 degrees. We look at the Harris measurement. We look at the orbital axial angle. That's the angle between the eyes and the axis, and that represents where they're looking, they gaze, because we don't want them looking too high or they won't be able to walk down steps. And if they're a student, we might want them looking down slightly. If they're really tall, we'll have them looking down slightly. If they're really short, we'll have them looking up slightly. So a lot of things go into this. We look at the occipital cervical angle, the distance from the mandible to the spine. If that's too close, they can have trouble swallowing. And it usually takes 3 or 4 iterations to get the head just right. And this is after we've eliminated all the rotation and tilt to establish orthogonality between the skull and the spine. So here's an intraoperative picture showing the screws and rods and then the fusion there. Now early on we used a system that had high profile, and here's the fusion. We're using rib bone, and the rib bone tended to heal really well. And here's the wound at 7 days and 1 month. So what did patients think? In looking back, I would choose still to have surgery, the craniovertebral surgery, and all of them said they would, to varying degrees of enthusiasm. I would feel comfortable recommending the craniovertebral fusion surgery to a family member, and all but one patient said they would. My quality of life was improved. Most people agreed. Most of these patients had so many other medical problems that it was hard for them to feel too much better from the neck surgery if they were disabled by postural orthostatic tachycardia and these other things. So the surgery improved my symptoms and decreased my limitations. Again, most agreed, but some patients had so many medical issues, that we didn't impact on their life enough. Now, in these patients using their autologous bone, we had a good fusion rate. I should mention that on other patients in whom I took it, not in this series, in whom I took the instrumentation out too early, the fusion failed. So you can't take the instrumentation out too soon, or in a hypermobile patient, that fusion can gradually reabsorb. So of the symptoms that got better, these ones got significantly better, not necessarily with statistical significance, I'll show you that in a minute, but the vertigo, tremors, fainting, headaches, balance problems, speech, numbness, neck pain, dizziness, leg weakness, memory, walking. So the symptoms on the right side are really mostly attributable to Ehlers-Danlos syndrome or the hereditary hypermobility disorder, and they did not, in general, significantly improve. So if we want to get a little more granular, you'll see before surgery, the red lines here show the average pain was about 8.4, and after surgery, the average was down to 4.3. The headache had not gone away, but it was substantially improved. But in these patients, there are many causes of headache, and so they should know that one surgery is not going to take away their headaches. Similarly with neck pain, the same phenomenon, substantially improved, but not gone. And dizziness, initially most patients had significant dizziness daily or many times a week, but at 2 and 5 years, the dizziness was not an issue for most patients. The same with vertigo. Walking problems were initially a very big issue. At 2 and 5 years, the blue on the green line, they were substantially improved. Same with balance. So if we look at statistical significance, we see that there's a 0.0001 improvement, or p-value improvement with the headaches, significant improvement with dizziness, balance. Memory problems were not improved in this group. Walking problems significantly improved. Vertigo in this group was sort of barely significant. Speech significant, and micturition issues were somewhat improved. Busy slide. Suffice to say that of those patients with neurologic deficits, about 2/3 of them showed normalization of their preoperative normal neurological deficit. Now, the Kanofsky score was originally designed for cancer patients, and it's been very well established in the literature. Let's talk about 10, which is moribund and a fatal, heading to a fatal end, and 100% is normal. And 70 is you're able to go to work. So most neurosurgeons we're quasi-disabled, but we're able to get to work every day. We barely make it to work and carry on. Not Dr. Oro, of course. He's 100%. I'm more on the 70% thing. So before surgery, the Kanofsky score was really low, around 53 was the average. And after surgery, it went up to approximately 70. So that was very significant. Now, were they able to go back to work? Even at 5 years, which is the green line, 60% of patients had not returned to work, but the total numbers of those who did return to work, if you look at part-time and full-time, there's 40% who are back to working as opposed to preoperatively, which is 25%. And I think if we looked at our data now, most of my patients are going back to school and back to work, and And I never fill out any disability paperwork because my goal is to get people back to a meaningful life, and not that they're not, all these patients are suffering, but I try to push them to as much as I can. Now, reasons for no improvement in work or school, 100% said there were other medical issues, musculoskeletal pain, fatigue, GI issues, POTS, dystonias, high intracranial pressure or spinal fluid leaks, fatigue, other joint problems, and other conditions such as clotting disorders, adrenal insufficiency. A lot of these, it's interesting, I think a lot of EDS patients seem to get in more motor vehicle accidents, probably because they're primarily women. Would you agree with that? Is that did you find? Okay. Several patients had other had other surgery. We'll go into that in a minute. Complications. Well, almost every patient had rib pain, which is why I stopped doing rib harvests, and now we use allograft from the bone bank. 2 had superficial wound infections, 1 needed blood transfusion. We didn't see any of these other problems, so I consider it a quasi-dangerous surgery, but interestingly, maybe because of the caution that surgeons use with this surgery, the complication rate is not so high, whereas a lumbar disc surgery is very common, but the published complication rate of that from Sontag's group was 11%. For lumbar discs. So we saw a 20-degree improvement in the clival-axial angle, so we reduced that kyphosis. And I think I just saw another paper recently where orthopedic surgeons are beginning to look at the clival-axial angle. They've always been very interested in kyphosis in the thoracic spine as a form of instability. And now people are beginning to see this kyphotic angle at the craniocervical junction as an important factor. This is a busy slide. Suffice to say that the clival-axial angles improved by at least 20. All of the pathological grab oaks measurements were made normal, and the horizontal Harris measurements were all brought into a normal range as well. So how reliable are the radiological metrics in determining the need for craniospinal fusion? You're going to hang your hat on this. Here's a patient I have been following her for years. She's got a bad-looking Chiari and a stretched brainstem and a bit of a kyphotic clival-axial angle, but her pain level is like 5. She's still working, so I said, you don't need surgery. And she's cooking along just fine. So, like the pirate said, these radiological metrics are guidelines, not rules. Yeah. So, does craniocervical fusion precipitate more surgery, like adjacent segment degeneration? In this group, we didn't see any early fusions at the C2-3 segment. So, strictly speaking, the adjacent segment would be to an occipital C2 fusion would be the C2-3 level. But within 5 years, there were 3 patients of this group that needed fusions from C2 all the way down to T1 because they had multiple level instability. And it's true to say that most patients with hypermobile EDS have premature degenerative disc disease, and they have lax ligaments, and so a strong proclivity to spinal issues. Now, of this group of patients, a lot of them had more surgery. So after the craniospinal fusion, none of this group needed a Chiari decompression, but let's see, 5 had a tethered cord release, 3 had an LP shunt, 8 patients had pain over the hardware involved in the craniospinal stabilization. So I stopped using that hardware a long time ago. And we haven't had, we've had very few hardware removals more recently. A number have had fusions at other levels posteriorly. 4 of the patients had ACDFs, anterior cervical discectomies. 3 within 5 years underwent a C2 to T1 fusion. 2 patients had thoracic fusions, and so on and so on. So does fusion cause disabling loss of range of motion? So theoretically, we lose about 40 degrees of rotation, or 40, even up to 50% of rotation, looking at those 2 motion segments, 1/3 of flexion extension. But here's a patient just 5 weeks after surgery, and it's difficult to tell that she has a limitation of rotation. And I don't think I've had any patients complain about loss of range of motion. Very important, there are many other missed causes of headache, and we've learned a lot in the last 10 years. This young lady on the left, typical degenerative disc disease, but otherwise normal-looking spine. Bad headache. I was sure she had a pseudotumor cerebri, but I sent her out for a flexion extension MRI, and we saw this compression of the spinal cord, and she got a simple discectomy fusion plating, and she's out of the hospital. She'd been in hospital for 3 or 4 weeks, and she's out a day after we did this and feeling great. So cervicogenic headaches are common. Don Long makes a big point of that with his series from Johns Hopkins. And Edward Benzel at Cleveland Clinic said that if you have a bendy spine, here's a normal neutral view, and then there's a extension view on the right, and you can see that the cord is stretching, and that stretching causes pain and neurologic deficit. This patient had a sinus thrombosis. She had a rapidly worsening headache, and she had leg weakness, and we obtained a study, and we found this thrombosis. And this patient had headaches with a vertebral artery dissection, and we see intracranial hypotension, where a CSF leak in the thoracic or lumbar spine or cervical spine can cause a low pressure system, and all the veins will distend and gorge, especially around the pituitary gland and over the surface of the brain. And so there are characteristic findings on MRI that can alert us to that, but that can present just like an intracranial hypertension, a high pressure syndrome. So occipital neuralgia can cause pain that's from the nerve coming out between C1 and C2, and that can get kinked on the hardware of the fusion, cause terrible pain in the back of the head, coming over the top of the head and behind the eyes. Tethered cord syndrome. At least half of tethered cord syndrome patients have headaches, usually in the suboccipital region. Now, this study was retrospective. All the subjects had multiple comorbid conditions of hereditary connective tissue disorders. And these comorbid conditions can somewhat obscure the outcomes. Subjects often had other surgeries. The Konopsky scores are well established, but they are subjective. And there's no control on this for placebo effect. And placebo effect is significant. So, in conclusion, earlier studies have suggested that mechanical deformative stress in the brainstem and upper spinal cord arise from a kyphotic clival axial angle, from a Chiari malformation, from ventral brainstem deformity, from craniocervical instability. And these stresses can result in a broad array of neurological findings, and reducing the mechanical deformative stress at the craniocervical junction with fusion and stabilization appears to reduce the number and severity of neurologic symptoms and deficits. And finally, dynamic imaging is often necessary to demonstrate the mechanical deformation of the central nervous system. I'd like to acknowledge the people I work with, from whom I've learned greatly, and thank you for your attention.